Typical day at work for an EMS provider, we have to have good time management, right? So as I mentioned earlier, we have to get to work before the shift starts. We need to check the unit, we need to check the equipment, we need to check the medication, right? Make sure all of that is good. We wait and we prepare. We respond to field emergencies, administer stabilizing gear, transport the patient to the most appropriate facility. We have to clean and restock the ambulance after the call is finished. Challenges in EMS in Jamaica. There is poor public awareness and education. That's a huge problem in Jamaica because the average Jamaican does not know who an EMT is and what an EMS system represents in Jamaica. There's a lack of proper government regulations and clearly defined scope of practice. The scope of practice in EMS is what you are allowed to do based on your level of training. The standard of care is how you perform that particular skill. I'll repeat that again. The scope of practice is what you are allowed, the skills that you are allowed to perform at the level that you're trained at. The standard of care is how that particular skill is performed. There is no regulated ALS service to utilize AEMTs and paramedics. That's a big issue because there will be emergency situations in the field that requires ALS intervention. All of the AEMTs that I've trained in Jamaica currently, they are not in the island. They are working in the Caribbean or in the United States because there's no system for them here to function effectively. There is underutilization and appreciation due to the length of time EMS providers are trained for. So EMTs can be trained for 9 weeks full-time, 3 months part-time. AEMTs, you're looking at 3 months full-time, 6 months part-time. A paramedic can complete their training in 1 year, 2 years, 3 years, or 4 years. Now, summary. EMS is essential to pre-hospital field care. There are BLS and ALS providers within an EMS system. A day in the life of an EMS provider is very dynamic and long, but it can be very exciting and memorable. And of course, there are major challenges that exist in EMS in Jamaica, right? We need regulations. We need accountability. The government is responsible for regulation, right? That's the end of my presentation. Are there any questions? Any questions?
Not at the moment.
Yes, there's a question from my end.
Go ahead.
You're saying that on the ambulance you don't have advanced life support, right?
Right.
That's what you're saying. So, for example, if there's a motor vehicle accident, there's not going to be any paramedic on that ambulance.
That is correct. That is correct.
So in Jamaica, you're saying that as it is now, really, if you are going to go to the level of a paramedic, you're either going to be in something like what you are now, which is education, or probably migrate somewhere to carry out your functions, right?
Not necessarily. For instance, if a EMS responder is going to work in the hospital setting, because we have EMTs that work in the hospitals, or the industrial setting, I strongly believe, based on my past experience, that if an EMS provider is going to work in the hospital or industrial setting, they shouldn't be below the level of an EMT, based on what they are allowed to do in the hospital and in the industrial setting. So there are avenues for advanced EMTs to work here in Jamaica. They are just limited. But naturally, if they should work within the Caribbean or outside of the Caribbean, there would be less limitations to that. I hope that answers your question.
Yes, it did. But sir, like for example, the scenario that you presented, the case that you presented at the outset, if
Yes.
we know that are being trained and the patient has hypoglycemia, we are not going to be able to administer, right?
Definitely not.
Right.
Not as an EMT.
So
But
basically, they would have to wait until they go to the hospital. So all that we are going to be doing is to just really transport the patient to the hospital.
no, there's a way of jumping the gun if we go into diabetic emergency. No. So there's a way around that. Right? And all that we do is not transport. So EMT is like a spare tire. Right? EMT is like a spare tire. You don't see the value of that spare tire until you need it. It doesn't matter how far you go in advanced care, you will always start with basic. Always. Don't matter how high you go, whether you're a surgeon, doesn't matter. If you have a patient that collapsed in front of you, you have to start with basic first. So basic will always come before advanced. And if your basic management is not good, your patient cannot survive. So it doesn't make sense that I can start an IV and give dextrose and I can maintain the patient airway and breathe for them. Basic before advanced. So the basic is just as important as the advanced care. That is very important for us to understand. You have another question, Ms. Denny?
Yes, Mr. Rufus. I wanted to know if you are already in the medical field, like the nurse, for example, and you're EMT now, does your ability to provide like IV medications and stuff, would that come in here?
Yes, you're a nurse, but even as a nurse, you must have some form of medical direction, yes?
Yes.
Right. So yes, if you're an RN, you can carry out your RN function.
Okay.
If you have to function as an EMT, it's more for field care, emergency care in the field, right? So you can balance that. But regardless of whether it's EMS or nursing, we need some form of medical oversight.
Yes.
We don't operate independently.
Got you.
Anybody else have any questions? You can raise your hand if you have a question, you know. Ms. Nesbitt, you still with us? Ms. Jackson, Ms. Johnson?
Still with you.
Okay.
Still here.
I'm here. Don't have a question.
All right. All right, so let's look at the US now. So that was a history really with Jamaica. Let's look at how things work in the US. All right, everybody seeing my slide?
Yeah.
Yes.
Yes,
All right,
senior
so
slide.
who is that? Who is that person? Rowan?
Yes, that's Rohan.
Yes. Please introduce yourself for me.
Okay, my name is Rohan Makelop, and I am all the way in St. James.
Okay.
Yeah.
Private candidate,
Mhm.
or you're with an organization?
No, I'm private.
Okay.
Yeah.
What's your reason for doing this course?
My reason for doing this course is the love for the emergency field and helping to save lives. More so, I have a passion for dealing with the persons who are in the healthcare areas who need assistance. And I love to go above and beyond in making sure that problems are being solved. And I realize, I would know over time based on observation and research, is that the emergency medical field is one that has a lot of issues to be resolved. We're saving lives or maintaining a healthcare uh, issues are concerned. So pretty much that is one of my main reasons for joining this.
All right. Welcome. Welcome.
Thank you, sir.
All right. Let us continue. So, still on introduction to EMS. We'll be looking at the emergency medical service system, and we're looking at it from the US perspective, right? So the curriculum that we use here in Jamaica follows the US curriculum that was designed by the Department of Transportation. We're going to be looking at the components of the EMS system and special issues. We're not going to touch the research portion that much, right? All right. So how it began in the States? It actually started from the 1790s in the Napoleonic Wars, right? During that time, the wounded was transported via horse-drawn carriages that evolved from there. We got the Civil War, we got World War I, we got World War II. Now, between World War I and II, we started to they started to use volunteer ambulance corps personnel to provide treatment to the injured soldiers in the field, right? And they started to say that some of these soldiers could go back into battle after they received treatment. In the Korean and Vietnam conflict, it evolved further, where we got the field medic, where you had a field medic with specific training that could provide specific managements. We had the helicopter to move patients to mobile army surgical hospitals or MASH units, right? So everything that we do in EMS, all of the equipments that we use in EMS, these are equipments and procedures that were first used by soldiers, right? And when they are outdated, it is passed on to the civilian EMS system. So the best medics in the world are actually found in the army, right? You're gonna find them in the armies. How it began. Non-military ambulance services began operating in early 1900s in the US, operated by hospitals, fire departments, or funeral homes. There was no requirement, there was no standards, there was no equipment, there wasn't any proper training, and the ambulance didn't have any specific design. That's a recipe for disaster, right? In 1966, a research article came out, Accident and Disability, Neglected Disease of Modern Society. And what research, one of the research article showed most of the deficiencies that were present in the EMS system at that time. And one of the important things that were highlighted from that particular research article is it showed that a significant amount of Americans were dying in motor vehicle accidents in comparison to the persons that had died in the wars. And after they saw that, they realized that something had to be done to regulate EMS response in the US. And that's how the Department of Transportation was formed. And their task was to develop EMS standards. In 1970, the National Registry of EMTs or EMS providers was founded. And the purpose of the National Registry really is to provide a standardized credentialing process for EMTs. So once you complete your training through a college or EMS school, you would test for the National Registry, and once you pass, you would be registered. And a lot of states require that for you to move from one state to another state. In 1973, National Emergency Medical Service System Act was passed, right? That's something you can read up on. Not going to go into too much detail on that particular act. Right? And eventually we got standards for EMS system through the National Highway Traffic and Safety Act, right? And these standards include regulation and policy. Each state establishes laws, policies, and regulation, resource management, centralized coordination of emergency treatment and transport resources, human resources and training, assure EMS personnel trained and certified to the minimum standards, transportation, provide safe, reliable transportation via an ambulance that is designed a specific way to transport specific patients. Facilities, transport to the closest appropriate facility, which is a very important point to note. So as when we have a patient that is critical, it's going to be the most appropriate facility, not the nearest, the most appropriate facility. Communications, universal system access number 911, dispatch to ambulance, ambulance to ambulance, ambulance to hospital, hospital to hospital communications, right? So you need a centralized dispatch system. That is something that is very much lacking in Jamaica. We don't have a centralized dispatch system. Public information and education. Educate public about role of EMS, access to EMS, participate in injury prevention programs. Public information and education, we need to do more of that in Jamaica as well. Medical direction, what very important element that must be a part of an EMS system. So EMS providers do not operate independently. We operate on the extension of the medical director's license in the field, right? So the medical director is responsible for the day-to-day operations of the system, and the medical director determine what you are allowed to do as an EMS provider within your scope of practice. Remember what I said the scope of practice is previously. It is what you are allowed to do based on the level that you are trained at. The standard of care is how you perform that skill. The medical director can limit the scope of practice, but cannot increase the scope of practice. So as an EMS wonder, you should not perform skills that are outside your scope of practice. The medical director provides online and offline medical direction, right? Offline would be standing orders, protocols. Online, you speak directly to the medical director to get advice. Trauma system. Develop trauma triage, transport, and treatment protocols. We need that in Jamaica. We're certainly getting a lot of trauma. And I stated previously that EMS started within the fire brigade. We have 34 fire stations on the island. Out of the 34 fire stations, we have 7 EMS stations currently, 7. And majority of these stations are in areas where we get a lot of tourists. The capital, Kingston, doesn't have a fire EMS response. What does that mean? It means that if you live in Kingston and you need an ambulance, the options for that would be a private ambulance, which you would have to pay for, or you put the person in a vehicle and carry them to the hospital. If it is the fire EMS, you do not pay out of pocket for fire EMS response. You just call them when you need them. 10, evaluation. Establish program for evaluating and improving effectiveness of quality improvement, quality assurance, and I don't remember what the TQM is. It's something to do with quality management. I don't remember what the T is. I need to double check that. Components of the EMS system. You have an emergency medical dispatchers. EMDs, or emergency medical dispatchers, work at the 911 dispatch center. Their role is to vet the calls when they come in and determine what would be the most appropriate EMS response needed. Do they need fire? Do they need BLS? Do they need ALS? Do they need critical transport? Emergency department hospital, which include doctors, nurses, allied health personnel, and we have specialty centers, which would include your trauma centers, your burn centers, pediatric centers, cardiac stroke centers. And even though it states trauma center, it is not specific to trauma calls. They can receive other patients. Think about it. Something to think about. What medical services are available in your community? So wherever you live, or do you have an emergency plan at home in case a family member or friend gets ill? How important is it that EMS personnel know the capabilities of community medical facilities? What are the possible consequences of transporting a patient to a facility not equipped to handle the problem? And I'm going to pause here for a bit to allow you guys to give some input on this particular slide. Anybody want to add anything or say anything? Can raise your hand. This thing need to be interactive, you know. Come on, people.
Do we have?
No, just tell me what you're thinking. No, doesn't have to be in any specific order. You can choose one, you can choose two, but just tell me what your thought process is.
I'll try the last one.
Go
What
ahead.
are possible consequences of transporting a patient to a facility not equipped to handle the problem? We have some facilities even now that they don't have an intensive care unit. Patient may require intensive care. Say, for example, you transport them to a facility that is deficient in this manner, then it would result in a delay in the patient getting the proper medical treatment, for example, being placed on a ventilator. So in that regard, I'm not saying, but suppose they transported them to Andrews Memorial, but really and truly, they don't have an ICU. So the patient, you could have saved time by just carrying the patient to UE. The patient may either die or the delay can cause some further complication in the prognosis or the outcome of the patient.
I definitely agree with that. And I think you are correct in that statement, right? So if you transport the patient to a facility that is not equipped to deal with the presenting problem, the patient's chances of recovery will drop very quickly. Anybody else want to comment on this slide? There's no right or wrong. I'm just trying to get your thought process. And it's an interactive thing, you know. I don't like just talking. I don't like talking to myself, right? So I expect you people to give input. Anybody else?
Yes.
That's
For
Miss
number,
Jackson.
yes.
Go ahead.
For one that says, how important is it that EMS personnel know the capabilities of community medical facilities?
Yes.
It has to be important that the EMS know, the personnel knows what each facility is capable of doing. So in a case where you have an emergency facility to take the patient to.
Excellent. Excellent. I would agree with that. No, Miss Jackson, can I ask you a question?
Yes.
Do you have an emergency response plan at home?
No.
You probably need to stop. Throw everybody in a taxi and drive go to you. Yes?
Yes.
So we need an emergency response plan. All right. Thank you for your input.
Mr. Rufus,
Yes.
might I just share
Go right ahead.
important a medical this plan would is because last year I my mother, and last year she had a heart attack. Really and truly, her doctor is way in Kingston, her hospital that she usually goes, but we're closer to the Spanish Town Hospital. And I would normally go through the whole process of whether or not something could happen like this, what would I do? And on that particular morning that she had the heart attack, sorry, we decided to go to the closest facility because the traffic would have prevented us from coming out of Portmore. And because of that, and we went to the closer facility, then she was able to start on the aspirin and the streptokinase that was needed to break up the clot. So those things, you know, because if we didn't have that plan of action, then we could have hesitated and that could have resulted in something really, really bad.
Quite so, quite so. An emergency response plan is extremely important, right? Because one of the things that we tend to forget is that, especially as healthcare professionals, it not gonna really happen to me right now, right? We can become patients, or family members can become patients, or friends can become patients. And we have to be prepared for that. Very important. All right. So let's look at this slide now. So when you, don't think I can make it any bigger, but you in the process. There is an incident. So there is an incident, right? Someone witnessed that incident, calls 911. The dispatcher answers the call, receive the information. Based on the information that is received, fire is dispatched, police might be dispatched, BLS response, ALS response. EMS arrive, we wait while fire extricate the patient. So EMS responders don't extricate, right? Firefighters would do that. Once the patient is extricated, then EMS would stabilize the patient and transport to the most appropriate healthcare facility within a specific time frame. Once the patient gets to the hospital, the doctors, nurses, and allied healthcare providers will provide definitive and therapeutic care so that the patient can recover. Now, this slide is extremely important, What happens if there is no dispatch system? Like Jamaica, for instance, there is no centralized dispatch system. So if you call the fire brigade or 110 or 119, you would not be able to get an ambulance in Jamaica, right? And if you cannot get an ambulance response, what are the bystanders in Jamaica typically going to do? They are going to try and move that patient on their own. And if it is a patient like this one that is in that vehicle that is involved in a car accident that might have spinal complications, they might end up paralyzing that patient or even killing the patient, right? So it's risky. So that's the EMS element. What happens if there is no BLS response? So if there is no BLS response, when the patient gets to the hospital, the doctors will now have to do BLS care. They basically have to do the care that the EMS providers should have done when they should be focused on definitive care. So there is a delay in treatment of the patient, and this will ultimately affect the patient's outcome, right? So all of these elements are important. But in Jamaica, for some reason, up to this stage, we cannot realize how important pre-hospital care is to a patient's survival. Hopefully, in the future, that will change. So accessing the EMS system, 911 telephone access. Now in Jamaica, you need to know the actual number of the ambulance service or fire station that you're calling for an EMS response. And it has to be one of the 7 stations that have ambulance response available. And all right, okay. And you have Enhance 911, which provides caller number, location for landline phones. Emergency medical dispatchers can provide instructions to callers on how to provide emergency care until EMS personnel arrive. And some of them are required to have specific certifications to work as EMS dispatchers. Critical decision making. Critical decision making is a very important concept in EMS. Information must be gathered. Patient must be assessed, and based on the assessment, you must determine what is the most appropriate treatment for the patient's condition and what type of transport is needed. Would it be lights and sirens, or routine transport, or just lights? And all of this need to be decided in a fairly short time. Examples of critical decisions. It is better to take patient to the closest hospital or to one further away, but more appropriate for the condition. So, excuse me. Is it better to take a patient to the closest hospital or to one that is further away, but more appropriate for the condition? What would be the choice there? Which one would we go to? The one that is closer or the one that is further
More
away?
appropriate for the condition.
Okay. Okay. Is the patient stable enough for further evaluation on scene? This is a decision that we have to make. So in EMS, we call it stay and play or load and go. And once you
Sir?
Yes, go ahead.
Yeah, can I ask a question?
Go ahead.
Just relating to the first question. So, yes, I would agree that it would be better to take the patient to the further away and more appropriate condition. But what if it's a case where the condition of the patient is extremely critical and you are at a particular location where you can stop to get some treatment just to add a little bit more time as it relates to lifespan to take the patient to the more suitable condition. Would that be something possible?
If the patient is critical and the closest hospital has the capability to stabilize enough that the patient can be transported to the most appropriate facility, that's fine. But if they don't have the capability, what would be the point? Right? So if they are able to stabilize airway, breathing, and circulation, you can stop there temporarily. But if the patient needs a particular surgeon, they have to go to the most appropriate facility for that. Right? So it's dynamic. Is the patient stable enough for further evaluation on scene, or should the patient be transported immediately? And as I said before, if it's a load and go patient, and a patient that is classified as load and go is a patient that, regardless of the type of intervention that you provide for the patient, you are not able to stabilize the condition. That's a load and go. If your patient has a compromised airway, that's load and go. Breathing, load and go. Circulation, signs of shock, that's rapid transport, right? Stay and play is a patient that the ABCs, airway, breathing, circulation, is not stable. Sorry, it's stable. Sorry, it is unstable, but your intervention stabilizes the patient, right? Will this treatment make the patient better or worse. So that is something very important. And in EMS, our objective is to do no further harm, act in good faith, and act in the patient's best interest. So we always do what is best for the patient. Now, levels of EMS training, we covered this in the previous slide. The EMR, medical responder, used to be called first responder. This is the first medically trained person to arrive. Police officers, park rangers, ski patrollers in the States. Then we have the emergency medical technician, which previously used to be called EMT basic. We have the advanced emergency medical technician. We have paramedics. And outside of these 4 levels, even though it is not within the DOT curriculum or stats, you have a critical care paramedic. You have also paramedics that go on to become PAs, physician assistants, and you have emergency practitioners. These are paramedics that have done additional studies. Roles and responsibilities. Personal safety. Your personal safety first. Your personal safety first. Safety of crew, patient, and bystanders next. We have to be able to perform a patient assessment. We must be able to provide the appropriate care. We have to do a lot of lifting and moving. It is a physical job, and you should be able to lift a stretcher between you and your partner with 125 pounds. And you should be able to carry your own body weight, right? So you need to be in good shape. Are we in good shape? I hope so. I hope so. Transport, transfer of care, patient advocacy. Think about it. How would it impact an older adult patient if they were transported to the hospital without glasses, hearing aid, or dentures? On a routine call, would taking the time to gather these items, routine call, mean it is not an emergency? It's not a life and death emergency. That's what routine call means. Would taking the time to gather these items have a negative effect on the patient's care? How about assuring the home is secure and locked before leaving? So let me hear your thought process on this particular slide. Please raise your hand if you have a comment. Come on, man. Go ahead, Miss Nesbeth.
Hi, Mr. Rufus. Me no monopolize the thing, you know. But, but part of the care of the EMTs, you're a patient advocate, so you're going to be doing everything to the best interest of the patient. In addition to that, one of our duties would be to, what do you call it? Is it orient? Give me the proper term, please. Like, to make them aware of where they are, and so orient the patient.
Orientation, you're talking about?
As in, let them be aware of where they are. So, for example, an elderly person that is deaf or can't see properly, they would have what you're saying to them. So it would, they won't be aware of probably where they are, what is going on. So the fact that we take the time out to, get the glasses and the hearing aids and so forth, it puts them at ease. So it allays their anxiety, orient them, as well as you'd be acting in the best interest of the patient. That's my take on it.
Quite so. I agree. Anybody else? This is an interactive session, I'm going to start asking you people to come on camera. Hold on, let me check this. Go ahead, go ahead.
Yes,
So,
oh, you can go ahead.
me?
I'm saying you can go ahead.
Okay, thanks. So, an elderly person, once a person gets older,
Yes.
they're a lot more scared out of their own house. So, if they're unable to hear or see or don't have in their dentures, and some of them are very self-conscious where that is concerned, they may get aggravated, and it would be difficult to transport them to a health facility if necessary, as well as it will pose a great difficulty in all respects.
I agree. I agree. When you have geriatric patients, you have to be very patient. You have to be prepared to do a lot of communication. Yeah, it's a call that takes time. I agree. Anybody else?
Yes, I have a question.
Go ahead.
So for the third one that says, how about assuring the home is secure and locked before leaving? Is it a case? Is it a case where, as the EMT, before leaving, is it a case where you are supposed to ensure that the home is secure and locked before you leave?
Remember what I said earlier. We act in the patient's best interest. Patient's best interest to do that.
Yes,
He's going
because
to be
there's
going to the hospital and his home is not locked up. Do you think if we spend some time to lock it up and make sure everything secure, it would be in the patient's best interest?
it would be, but what if it's a case where there's a life and death situation where you really have to
No,
rush
no, no,
out?
no. So the question here has nothing to do with the situation. So this is one of the things that I'm going to point out to you guys now. So when you have a question, right, or a situation that you need to address as an EMS provider, you need to manage what is presented. Don't add to the situation. So the slide said routine call. A routine call means it's not a life and death situation. If it's a life and death situation, then the approach would be different. We would have to have law enforcement involved, right? And we will be securing ABCs as quickly as possible and moving the patient. So learn to focus on what is presented. Don't add to, don't subtract from the presentation. Just manage what is presented. All right. Could the concept of patient advocacy also extend to the community, fall prevention programs for elderly, poisoning awareness, pool, water safety programs for children, right? So start thinking about how you can educate the persons within your community as to what is the role of EMS providers, why is it important? And if you can even offer them some first aid training too, teach them a thing. Teach them how to control little bleeding, right? Teach them how to move a patient tongue out of the airway until EMS arrives, right? So there's a lot we can do for our community, and we need to be more involved. Now, physical traits of a good EMT. Ability to lift and carry equipment and patients up to 125 pounds. How many persons exercise? Or how many persons work out? Go ahead, Ms. Nesbitt. Go ahead.
Oh, my hand wasn't up, but I don't exercise. I'm very embarrassed about that though.
Okay. So we need to be in good shape, right? We need to be able to manage the weight of the patient and the stretcher and the equipment on the stretcher. Good eyesight is also important, right? Good communication skills, and we're not doing it all by ourselves. We're working in a team, so it's a team effort. It's not what I think we should do. It's what we should do, right? It's not, okay, we need to do this. It's what we should do. This would be the best thing for us to do for the patient, right? Team effort. Pleasant, sincere, cooperative, resourceful, important traits. Must look professional, right? Must look professional. Self-starter, emotionally stable, able to lead, neat and clean, of good moral character, and respectful of others, right? You have to genuinely care about the patients that you're treating. That's very important. In control of personal habits, controlled in conversation and able to communicate properly, able to listen to others, non-judgmental and fair, right? All of these are good traits or personal traits that you should have. Education, important slide. As an EMT, once you have completed our course here at UE, you will be issued a certificate from the University School of Nursing. That certification will last for 2 years. After 2 years, you need to do what is referred to as a refresher or recertification course. Once you are working without an up-to-date certification, that can be seen as negligence, right? And it is simple. If I am a patient, I don't want a doctor treating me if his license has expired. I wouldn't want a nurse either, and I certainly wouldn't want an EMS provider treating me if they are not up to date. It's just wrong, right? And if you're not up to date with what is happening, you can make serious mistakes. And the commandment in EMS is, thou shalt not do it, what thou cannot take it back. That is our commandment. Continuing education courses, CME online courses, your BLS, ACLS, basic life support CPR courses, advanced cardiac life support courses, pediatric advanced life support. You can go to conferences, seminars, lectures, right? All of this is important too, maintaining the skills and the knowledge. No, that is going to be very challenging for some of you doing this course right now, because EMS response is not your primary job. It's an additional skill, right? But based on your setting, whether that's the pharmacy, whether it's the terminal, the possibility exists that you can have an emergency where the skill is needed. So it is important that you come up with a way that you can maintain that knowledge and skill, that when a situation arises, you don't have to think about it. You just respond, right? So maintaining the skills and the education is important. Think about it. How will you refresh your knowledge and stay current once you are out of the classroom? What qualities would you like to see in an EMT who is caring for you, who is caring for you, how can they come closer to being this kind of EMT? I think that's what that is saying. Comments. How do you intend to maintain the knowledge and the skills after you leave the classroom? What are some of the qualities that you would expect to see in an EMT if they were treating you? Any comments on that? Go ahead, Ron.
Yes, sir. So as it relates to the first question, how will you refresh your knowledge and stay current once you are out of the classroom? I believe that it would be important to keep in touch with persons who are presently or currently working within the medical response area. Also, it would be good to keep up to date with new implementations of how you go about treating different type of traumas, and it would be important for yourself also, if you are not working as yet, as soon as you leave school, to make a check every now and then to see what is really happening in the emergency response department.
Okay, I hear you, but that's going to be a difficult task outside of the classroom, right? And you're going to need to have intrinsic motivation. If you don't have that, it's not going to happen, right? That's going to be the hardest thing after you complete this course. Staying up to date, staying current. Any other comments? Go ahead, Ms. Nesbitt.
No,
Yeah.
it is kind of worrying that, I mean, I'm sure that there are a couple EMTs in Jamaica, and I'm almost sure that you're not the only paramedic in Jamaica, right? Am I correct? Right. So I am at a loss as to why it is that we, well, as a group, then more persons like you don't go into providing these continuing education seminars. I mean, you're trained above the EMT levels. You're current with world something. You guys can get together, do seminars, probably because I'm talking from a pharmacy point of view, and this is something that we have only per times per year. But this is something that needs to be done. I think in this day and age, why is it that we have to go online to do a continuing education course when we have so many trained individuals here who could organize it? And we come in once or twice per, I don't know, per quarter, and you can get points from your education, your continuing education seminars. I think this is something that needs to be formalized when it comes on to the group of EMTs and paramedics and whoever else. If it's even medical directors can come together, and this is something that I think, because it is not very formal, you don't have, the framework is kind of everywhere, so this is not being taken care of when it should be, sir.
I hear you. And my response to that is this. So remember in my previous slide, I stated that there is no regulation that exists in Jamaica for EMS providers. And this is how it works. If there's no regulation, there is no accountability. If there's no accountability, then a lot of these responders that are out there currently have no incentive. It's not mandatory for them to be up to date because the government is not regulating it, right? So there are a lot of EMS providers that slip under the radar, right? And I agree with you. We have went as far as organizing workshops. We have organized free workshops, and the turnout was very poor when we did that particular workshop at UE, it was doctors and nurses that turn up and less than 5 EMTs, right? So until the government decides to regulate EMS and set a designated scope of practice and guidelines for refresher, we're not going to have that happening right now, right? Not going to have that happening right now, unfortunately. All right, hold on. I think I may have gone too far ahead. All right, good. Where will you become a provider? So you have EMTs that work in private ambulance setting or private ambulance services. You have EMTs that work within the fire department. And I strongly believe that every firefighter should be a EMT or have some form of EMS training. Currently, they are trying to implement that. You have rural wilderness teams, they are called remote EMS providers. And you have your city EMTs and you have your industrial setting, right? And you have your volunteer. All right, so the National Registry of Emergency Medical Technicians. I spoke about this previously. It's a national credentialing body that offers examinations for all 4 levels. And once they have passed this examination, they are given a registration number and they are able to do what is called reciprocity. And that is when a provider would like to move from one state to another to work as an EMT. In Jamaica, we don't have a Jamaican registry. What we do have within the Caribbean is a Caribbean registry, which falls under the Caribbean Association of Fire Chiefs. And it is similar to the National Registry. They offer a standardized credentialing process by testing skills and doing a written examination. And once the EMTs pass this examination, they are given a Caribbean registry certification with a registration number, and they are placed on the CEDEMA website, right? And I am a proctor examiner for the Caribbean registry. Quality improvement. Continuous self-review with the purpose of identifying aspects of the system that require improvement. Develop plans to correct deficiencies and improve performance. So this is something that has to be ongoing. Everyone in the organization has a role, preparing carefully written documentation, becoming involved in the quality process, obtaining feedback from patients and hospital staff, maintaining your equipment, continuing your education. Medical director. All patient care performed under direction of a medical director. So it cannot be an EMS response system without a medical director, right? Ultimate responsibility for patient care, oversees training, develops treatment protocols, issues offline medical direction or standing orders, and provides online medical direction. EMS role in public health. Injury prevention for geriatric patients, injury prevention for youth, public vaccination program, disease surveillance, right? These are some of the things that EMS has a role to play in public health. Now, the next section of the slide focuses on research, and as I say, I'm not going to go into this too much, but what is important for you to note that for EMS to move forward, whether it's in the US or other countries or in Jamaica, research is going to be extremely important to that. And it is something that I am focused on doing, right? So I'm looking at EMS research for my graduate studies. That's the area I want to focus on. We have not had a lot of research articles over the past 2 decades as it relates to EMS response in Jamaica. So the more research we can produce, I think it's the more we will get the government to react and put certain things in place, because they do know the importance of EMS response, because they are using a lot of these responders for a lot of events. All right, and that brings us pretty much to the end of the slide. Let me just go to the review quickly, and then we'll take a 15-minute break. All right, so EMS system has been developed to provide pre-hospital as well as hospital care. EMS system includes 911 or another emergency access system, dispatchers, EMTs, hospital emergency department, physicians, nurses, physician assistants, and other health professionals. The EMT's responsibilities include safety, patient assessment and care, lifting and moving, transporting patients, transfer of care, and patient advocacy. An EMT must have certain personal and physical traits to ensure the ability to do the job. Education, including refresher training and continuing education, quality improvement procedures, and medical direction are all essential to maintaining high standards of EMS care. Remember, EMS dates back to Napoleonic times. Modern EMS standards come from 1960s to 1970s, and the National Emergency Medical Service System Act. There is a chain of human resources involved in EMS. Critical decisions are made by each member of the chain. And once there is a break in the chain, the patient suffers. And at the end of the day, it's about patient care. That is what it is about, right? Patient care. There are certain personal and physical traits that help you to be a successful EMS provider. An EMS provider should actively pursue opportunities to improve personal knowledge and abilities, as well as the unit's overall quality. Questions to consider. All right. We will move past those questions for now. Critical thinking. Your patient is hesitant to go to the hospital because she is worried about her dog. What can you do to assist this situation? What part of your role as an EMT is the example of. Anybody want to try that one? Anybody want to try that one? You still with me, Ms. Nesbeth?
Still with you, sir.
The others?
I'm here.
Still here, sir. All right. Let me give it a try. So the patient is hesitant to go to the hospital because she's worried about her dog. No,
Yep.
I strongly believe that in maintaining the health of a particular patient while taking that person to the hospital, reassurance or I would say affirmation is very important, because no one wants to die. Well, except for those who are old and probably want to get out of pain if they are sick. But nobody really wants to die when they're feeling ill and so forth. So just as though you would comfort the person with words, tell him him or her that they'll be okay. Then in a situation like that, I mean, you would have to be very much bring about comfort, or reassure the person that the dog will be okay. You'll try to probably get somebody to look after the dog or something.
So who you got?
The neighbors.
Okay. Okay. Anybody
Yeah.
else? Anybody else? So, go ahead, Ms. Nesbeth.
Part of the role of the EMT is to provide to your patient, right? So
Right.
the fact she's troubled, she's worried about her dog. Then since it's really a patient-based care, then like Ron said, I would make some arrangements with the neighbor to just assist to take care of the dog while she's away. Because I mean, being empathetic, because that's part of our role as well. So I put up myself in her position. Probably the dog alone is our company, and she worried about the dog. So I would ask the neighbor, please, if he or she could just look at the dog until the patient comes back from the hospital, or even if a family member we can call a family member, because more than likely the patient has a number for the family member. Call the family member, say to the family member, okay, the dog is here, could you come and see that the dog is okay, check in on the dog and whatever. I would do that.
Fair enough. Miss Dennis, let me hear your thoughts.
Yes.
What are your thoughts on this question?
I was about to say I would get a number for the person's relative if they have any available, or if the neighbor and the person is close, would either
Okay.
ask the relative or the neighbor to, if they could see look after the dog until the person is back, or until they get somebody else who is more capable to take care of the dog, just to
Okay.
give the person some peace of mind.
All right, good. So I'm hearing the thought process. Miss Johnson and Miss Jackson, I need to hear everybody. This is
Okay.
critical.
What I would do is, because a lot of persons have there are certain way with their dogs, so I think
Yes.
the best thing to do is to ask them if they have anybody in mind who they wish to, look after the dog while they're away. 'Cause most of the time sometimes they travel, or they go different places and they have a specific person to take care of the animal. So we could ask them if somebody like that is available, and if they are, we could get the person's number, or if they're in a position, we could ask them to call the person and make some arrangements.
Sounds good. Sounds good. So I'm hearing the critical thinking so far. Miss Jackson, let me hear your thoughts.
Yes. Yes. the patient, you have to take the patient's feelings and thoughts into consideration. So yes, you'd have to ask the patient what he or she would be most comfortable with. More than likely, in some instances, they won't want to leave the dog at all. So for example, it's a service dog. You know, like those people with disabilities who need to have their
Right.
dog around.
Right.
In some instances, they have ambulance care that accommodates the animal, accommodates the dog. Once it's a
Right.
service dog, and they usually have something to identify a service dog. If it's a case where it's not a service dog, well, they're not going to accommodate them in an ambulance. So you'd have to ask the patient if there's like anyone else that could look after the dog until he or she is able to come back home.
Okay, sound good. You people are bright, man. If you people were on camera, I would need glasses. They're extra bright. Now, one of the things that you can also consider apart from getting the patient input and communicating with neighbors, you can actually call the fire brigade. I can remember one call where I had to call the fire brigade for that dog, right? So you can get the fire brigade involved, and there's a saying in fire brigade, we call them for everything. So on that note, we will take a, now is what, 5:40. We will resume at 6 p.m. So take a little break, get something to eat, and if you can, and we will resume at 6 p.m. and we'll be going into medical terminology next. All right?
Okay.
All right,
Okay.
cool. We
Okay.
continue.
Break that.
Mute your mic while you're on your break. Mute your mic.
How was it? No. Woo. 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 Mwah.
I am back. We won't start until 6. If you have any questions, I can answer. Rowan? Not hearing you.
Sir,
Are you using a computer or your phone?
I'm using my laptop, sir.
Okay.
Yes. Okay, so you're looking at the next topic that we're going to be looking at.
Sorry?
I'm just here reading up on the next topic that you'll be looking at, the medical terminology.
Okay.
Yeah.
We'll be starting in 5 minutes. Everybody hearing me okay?
Yes, I'm hearing.
Yes, sir. 5 minutes and counting down.
Miss Jackson, you hearing me?
Yes, I'm hearing.
Danielle?
Yes.
All right, good. Good. I was trying to find information earlier, but I found it now. So I had mentioned that there are only 7 EMS stations within the Jamaica Fire Brigade. These stations are located in Ironshore, St. James. There's one in Negril. There's one in Sav, Lucy, Hanover, Falmouth, Trelawney, Linstead, and Portmore. These are EMS response stations that if you call, you don't have to pay up front. You hearing me, Ms. Nesbeth?
Yes, I am.
All right, good, good, good. All right, let us continue. So we'll be looking at medical terminology, which is chapter 5. This particular chapter it is important for you to review this chapter if you have no prior, if you don't have a medical background, right? This chapter would be very important before going into the human body. Medical terminology uses foundational anatomical and medical terms and abbreviations in written and oral communication with colleagues and other healthcare professionals. Introduction. So as EMTs, we need a working knowledge of medical terminology, right? It will help us to understand key terms, acronyms, symbols, abbreviations, right? And acronyms are words. Well, they are letters, a group of letters that when they can pronounce a word, right? And these group of letters have specific meanings. For example, the acronym SAMPLE can pronounce a word, but each letter represents something specific. So S would be signs and symptoms, A would be allergies, M, medication, P, pertinent past medical history, L would be last oral intake, and E would be events leading up to. right? So in essence, an acronym is an abbreviation, but when you call it, you call a word. We, as EMS providers, we need to be familiar with medical terminology to determine the meaning of unknown words, right? And we would be able to do that if we have an understanding of how the word is formed and we learn the definitions of parts of the term. And of course, it will help us to understand the medical jargon and help us to communicate with our peers, not necessarily the patient. So we don't want to get technical with our communication when we are talking to patient. We need to make it as simple as possible that they can understand what it is that you're doing. Anatomy of a medical term. Medical terms are made of distinct parts that perform specific functions. Changing or deleting any part can change the function or meaning of a word. The components that comprise medical terms include word root, prefix, which is at the beginning, the suffix, which is at the end, and the combining vowels, which you use it to combine root words, right? Or it may be necessary to make the word easy to pronounce. How the parts term are combined determines its meaning. Accurate spelling is essential, right? And they give an example. So you have fascia and fascia. So you have one with SIA and one with GIA. They are pronounced the same, spelled differently, and they have different meaning. Fascia means speaking. That's the one with the SIA. Fascia with the GIA means eating or swallowing. Now, if we add the prefix dis, which means difficult or painful, we change the meaning of the word. Dysphagia with the SIA means difficulty speaking. Dysphagia with the GIA means difficulty eating or swallowing. How the parts of a term are combined determine its meaning. Right? And this is very important. Right? For you to understand the context. Are you guys still seeing my slide?
Yes, I'm seeing it.
Yes, sir.
Yeah.
Still.
Okay. Just checking.
Yep.
Just checking. All right. So how the parts of a term are combined determines the meaning, right? And this is going to be important. It will help to develop your knowledge of anatomy and to understand the context of how these words, the context that these words are used in. Word roots. This is the main part or stem of a word. It conveys the essential meaning and it frequently indicates a body part. Words, if you add a prefix, which is at the beginning, or a suffix, which is at the end, you can change the meaning of the term. Cardiopulmonary breaks down into cardio is a word root meaning heart, and pulmon is a word root meaning lungs. During CPR, you introduce air into the lungs and circulate blood by compressing the heart. That's cardiopulmonary resuscitation. Prefixes appear at the beginning of a word, usually describes location or intensity. It can also describe direction and numbers and colors. Usually describe location or intensity. Also found in general language, example, autopilot, submarine, tricycle. Not all medical terms have prefixes. Give the word root its specific meaning. So if you add a prefix, it will change the meaning of the word root. And we have an example here. For the word root, pnea, which is associated with breathing, one can add the prefix a or a without, brady, which is slow, tachy, which is rapid. If we add a to pnea, it becomes apnea. Apnea is without breathing or no breathing. Bradypnea would be slow breathing, and tachypnea would be rapid breathing, right? So by adding 3 different prefixes, we get 3 different words. By learning commonly used prefixes, you can figure out the meaning of unfamiliar terms. Suffixes appear at the end of words, usually indicate a procedure, a condition, a disease, a part of speech. Suffixes commonly use suffix itis. Itis means inflammation. And if you come across the word itis in your text and in your studies as we go forward, it will be associated with inflammation. When we start to think about inflammation, we're thinking about swelling, we're thinking about leakage of fluid, right? Paired with arthro, which is joint, creates arthritis, which is inflammation of the joints. Combining vowels. Connect word root to suffix or other word root. Most cases, it's an O, may also be an I or an E, used when joining a suffix that begins with a consonant that will make it easy for the word to be pronounced, or when we have to join 2 word root. Example, gastroenterology. Gastro is stomach, entero, intestine. Logy is study of. So gastroenterology is a study of the stomach and intestines. Combining form, a combining vowel shown with the word root. Some common combining forms that you definitely need to be familiar with, and some of you might already be familiar with them. Cardio, heart, gastro, stomach, hepato, liver, arthro, joint, osteo, bone, pulmono, lungs. Now, these are the rules, right? Summary of the rules. Prefix is at the beginning of a term. Suffix is at the end of a term. Use of combining vowel is needed if the suffix begins with a consonant. It will make the word easy to pronounce. Or you need to combine 2 word root. Let's look at plural endings now. So these are the rules that we will apply. Sometimes you add S. So sometimes you're just gonna add an S. 1 lung, more than 1 lungs. Words ending in A, we will add AE. So 1 vertebra, more than 1 vertebrae. Words ending in IS, we add ES, or change to, I should say. We change to ES. One diagnosis, many diagnoses. Words with EX or IX, we change to ICES. Apex, one, more than one, apices. Words with ON or UM, you change to A. Ganglion, one, more than one ganglia. Ovum, one, more than one ovum. Words ending with US, you change to I. So it's one bronchus, more than one bronchi. So these are some rules you definitely need to be familiar with. Now, special word parts. So prefixes can indicate numbers. It can also indicate colors, positions, and directions. Numbers. Some prefixes indicate that a term involves a number or two or more parts or sides. Example, uni, one, dipple, double, null, zero, or nothing. Primi is around, I think. I need to double check that one. Multi, more than one. No, primi is one. Sorry. Primi is one, multi, more than one, by two. So primi is one. Colors. Several word roots describe color. So examples, cyano is blue, cyanosis, bluish discoloration of the skin that indicates poor oxygenation. Leuco, white, leukocytes, white blood cells. Erythrocytes, erythro, red, right? So erythrocytes, red blood cells. Cero is orange or yellow. Melano is black. They can indicate position, direction, or location. Prefixes. Examples. AB, ab, means to move away from. Sorry, yes, move away from. That's AB. AD, move towards, ad. DE means to move downward, circum, around, very similar, around. Trans, to pass through. Epi is above, supra is above as well. Common direction, movement, and position terms. Directional terms. Need directional terms to discuss where an injury is located and how pain radiates in the body. So we're now going to say the patient broke him hand on that side over there. So yes, down on the elbow side on that side. We have to be specific, right? When we're relaying this information to our colleagues or the doctor or the nurses, whoever we're handing the patient to. Some directional terms that you definitely need to be familiar with. Right and left, and when we say right and left, it is the patient right and left, not your right and left. The patient right and left. Superior, closer to the head. Inferior, closer to the foot. Lateral is away from the midline. Medial is close to the midline. And you have proximal and distal. Now, let me pull up the whiteboard for a sec. Everybody can see my whiteboard?
Yes, sir.
Yes.
All right, so I can't draw very good, so work with me. Work with me, right? Work with me. All right, let me try. All right, so let's say this is our long bone, right? and do not criticize my bone. All right. Oops. This is what I want here. All right. So this would be proximal. Down here would be distal. All right. So when we talk about proximal and distal, we apply that to a long bone, right? So I'm not going to tell you that the patient, I'm going to give you a scenario and say the patient has a distal fracture to the femur. So if I tell you that the patient has a distal fracture to the femur, you need to know exactly where I'm talking about, right? And that's how you would relay that information. So distal and proximal is applied to long bone. You always think about the long bone that is involved. And every long bone has a proximal end, a distal end, and a shaft. The shaft is usually the mid portion. That's the mid region, right? So the shaft would be in this region here. Right? That would be the shaft. Now the proximal end will be closer to the trunk of the body. And the trunk is considered to be the chest, abdomen, and pelvis without the head and limbs. I'll repeat that. The proximal end would be the end of the long bone that is closer to the trunk of the body. The term trunk is used for the chest, the abdomen, and pelvis without the legs, arms, and head. That's what we refer to as the trunk. If the portion of the long bone is closer to the trunk, it's considered to be proximal. If it's further away from the trunk, it is considered to be distal, right? Now I'm going to ask a question to see if you understand all of that nonsense I just mentioned. If I said to you that a patient has a fracture of the humerus, and that's the bone of the upper arm, right? Humerus. At the just above the elbow. So the patient has a fracture just above the elbow. Would that be the distal end of the humerus or the proximal end of the humerus? Raise your hand if you know the answer. Or I'm going to call in somebody. Anybody? Go for it. Let me repeat again. The patient has a fracture to the humerus, right? Just above the elbow. Is that distal or proximal? Go ahead, Miss Nesbitt.
It would be distal.
Okay, I hear distal. Miss Dennis, you had an answer? Miss Johnson, go ahead. Go ahead, Miss
Proximal.
Johnson.
Proximal.
Okay, Miss Dennis. Okay. Ruan.
Yes,
Where are
sir.
these people?
I would say distal.
Okay. Where's Miss Dennis and where's Miss Jackson?
Distal, Mr. Rufus.
Okay, Miss Jackson.
It's distal.
Okay. All right. All right. So the response is the distal end of the humerus would be closer to the elbow. The proximal end would be closer to the shoulder. So if it's if the fracture is just above the elbow, it would be the distal humerus. It wouldn't be proximal. That would be the distal end of the humerus. So once you have a question like that, you have to identify the bone that is involved, right? So the bone involved would be the humerus. Okay, this is the humerus. One bone involved, where is the distal end? Where is the proximal end? Where's the shaft? The proximal end will always be closer to the trunk. The distal end will be further away from the trunk, right? All right, so that's proximal and distal. I didn't want to just mention it on the slide. If I can depict it, it would be easier to understand. So look out for that one. You might definitely see it again on an exam paper. All right. All right, let's get back to the slideshow. All right, so we were at all right, we were at directional terms. Let's continue with that. All right. All right, so I'll go into the lateral and medial when I start the human body. I don't want to touch that one now because my art skills are not good enough yet to draw a body. So when we start the human body, I'll talk more about the lateral and medial. For now, just understand that the lateral end would be closer to the midline. The midline is a line drawn from the head, center of the head down between the legs that cut the body into right and left halves. Any structure that is close to that center line is referred to as medial. Any structure that is further away from that center line is referred to as lateral. Superficial would be closer to the surface of the skin or top surface. Deep would be more into the tissues. Then we have ventral, which is the same as anterior. You will see anterior used more than ventral. Dorsal is posterior. You will see posterior used more than dorsal. When we use the term palmar, we're talking about the palms of the hand. Plantar, that's the foot bottom, right? Apex is the point of a structure, right? Regardless of the direction, right? For instance, the apex of the lungs is in the clavicular region, right? Or your collarbone. And the apex of the heart, you're going to find that in the fifth intercostal space below left nipple. But don't worry too much about that right now. We'll get into that more in depth later on in the course. So superior and inferior. Superior, nearer to the head. Inferior, nearer to the feet. Terms describe the relationship of one structure to another. The knee is superior to the foot and inferior to the pelvis. Lateral and medial. Lateral, outer, body parts that lie farther from the midline. In general, lateral means side. Medial, inner, right? And your arms or upper extremities, or your legs or lower extremities have medial and lateral sides, right? Very important for you to note that. Body parts that lie closer to the midline. Example, 5 centimeter laceration on the medial aspect of the thigh. That's the inner thigh. So medial aspect of the thigh would be the inner thigh. Lateral aspect would be the outer thigh. Proximal and distal. Just talk about that one there, just showing the Bosi drawing, right, with the long bone. When we talk about proximal or distal, you have to think about the long bone that is involved. So if it's the radius and ulna, you need to think about where is the distal point of the radius and ulna, where is the proximal end, where is the shaft, right? The distal end will always be further from the trunk. The proximal end will always be closer. The elbow is distal to the shoulder and proximal in relation to the wrist and hand, right? Superficial and deep. Superficial means closer to or on the skin. Deep means farther inside the body tissue, away from the skin. Examples: superficial sunburn, top layer of the skin affected. Deep laceration equal a cut deeper into the tissue. So it goes deep into the soft tissue, right? Deep. And backtrack a little bit. Okay, can go forward. Ventral and dorsal. Ventral refers to the belly side of the body, anterior surface of the body. Dorsal refers to the spinal side of the body, posterior surface of the body. Example, dorsal fin of a dolphin. Ventral and dorsal. Continued. More commonly used terms are anterior and posterior. So you will see anterior and posterior more, right? Palmar and plantar. Palmar surface, front region of the hand, the palm. Plantar surface, bottom of the foot. Apex, apices, tips of a structure. Apex of the heart is the bottom inferior portion of the ventricles. All right, movement terms now. So we have bending of a joint, and we have extension of a joint, and we have adduction and abduction. So let me utilize my whiteboard skills again, right? Don't discriminate against the drawing. All right, so everybody see my arm? Or something that looks like an arm? Everybody can see that?
Yes.
Yes, sir.
Yes, sir.
All right. All right, so no. So the first drawing, or this one, let's put it over here. That's the elbow bending, right? So the term flexion refers to a limb being bent or brought closer to the body. That's flexion, right? That's what we refer to as flexion. The one on this side is the elbow extending, and that would be extension, right? So that's flexion and extension. Now, if the elbow is bent and it exceeds the normal range of motion, we would refer to that as hyperflexion, right? And if it is extended beyond the normal range of motion, it would be referred to as hyperextension. So that's flexion and extension. Now, if this is the body and this is the arms, right? So this is the arms. Everybody seen that bottom diagram? I know it's not that wonderful, but just try and get a concept. So that's the body, right? The arms are moving away from the body, right? So the arms are moving away from the body, but they are not flexed or they are not bent, right? Once the arm moves away from the body, that would be what we refer to as abduction. So that's abduction, right? Body again, but this time the arms are moving in. So the arms are now moving in. Not flexed, but they are moving towards the body. When the arms move towards the body and they are not flexed, that is referred to as adduction, right? So, do we understand the difference between flexion and extension and abduction and adduction? Just give me a strong yes. We clear?
Yes.
All right, good. Oops. Let's go back to our slides. Let's go back down the line. All right. All right, so we were on flexion, extension. Right, this is where we were. So flexion is the bending of a joint. Extension is the straightening of a joint. Adduction, motion toward the midline. The arm is not flexed. Right? Abduction, motion away from the midline. So it's movement away from the midline. Other directional terms: bilateral, equal both sides of the midline. Example: eyes, ears, hands, feet. Structures inside the body also appear on both sides of the midline. Example: lungs, kidneys. Unilateral, only one side of the body. Example: unilateral chest expansion, which you might see that if your patient have a collapsed lungs. You might only see one side of the chest rising. That would be unilateral chest rise. Other directional terms: you have the abdominal cavity, which is divided into 4 equal quadrants. You have the right upper quadrant, left upper quadrant, right lower quadrant, left lower quadrant, right? And there are specific organs that are found in these compartments or quadrants. We won't go into that right now, but certainly we will be looking at that when we cover the human body. Other directional terms, learn these concepts to describe location of an injury or assessment findings, right? Important. So medical personnel will know where to look and what to expect. That's the whole point of learning these terms. We'll use it to describe the location of injuries. We'll use it to describe how the patient is feeling pain, right? All right, now let's look at some anatomic positions, right? And I'll talk about the normal anatomic position when we cover the human body. For now, just looking at these positions, right? So you have prone or supine. Prone means the patient is lying face down, right? Supine means the patient is lying face up. And you have the Fowler's or sitting position. It can be high Fowler's or semi-Fowler's, right? Some semi-Fowler's is a 45-degree angle, high Fowler's is a 90-degree angle, right? And the Fowler's position is a position that you want to keep a patient that is communicating with you who is having trouble breathing in, right? You want to keep them upright. If you find a patient prone, you definitely don't want to keep a prone patient lying face down, right? And if you think about it logically, you will understand why. If a patient is lying on in the face down position, it means they're lying on their chest and abdomen. If they're lying on their chest, it's going to be difficult for them to have good chest expansion. So it's going to interfere with their ability to breathe. So you always want to turn your patient over in the supine position, right? Especially when you're going to manage the airway. So prone, face down, belly surface, right? Supine, lying face up on the back, Fowler's sitting position, and it can be either semi-Fowler's, which is 45 degrees, or high Fowler's, which is 90 degrees. All right, breaking terms apart. Use the meaning of parts to decipher the term, right? Define in this order, the suffix, the prefix, the word root. And we're just going through some examples now. Neuropathy, nephro is pathy. What am I saying? Nephropathy is the word, right? Look like my brain is shutting down. Pathy means disease. O is the combining form. Neph is kidney. Nephropathy, disease of the kidney. Dysuria. Ear means condition of. This means difficult, painful, or abnormal. Ur means urine. Dysuria, painful urination. Hyperemesis. The prefix hyper means excessive. Emesis is vomiting. Hyperemesis, excessive vomiting. Analgesic. Ik suffix meaning pertaining to, and prefix meaning without or absence of. Alges, word root meaning pain. Analgesic, pertaining to, no pain. All right, now abbreviations, acronyms, and symbols, right? Now this part of the slide, yes, you can use abbreviations, you can use acronyms, and you can use symbols. What you need to ensure is that the abbreviations, acronyms, and symbols that you're using are universally accepted. You have to be careful how you use some of these abbreviations in your report, right? It's better to write your report simple than complicated, right? Because if it's complicated, it is now open to interpretation, right? Now open to interpretation. So I'm not going to spend a lot of time on this portion of the slide, right? Because I don't push the use of abbreviations and acronyms. But they can be used based on what is universally accepted. So let me go back to the infamous whiteboard. No. So you see this acronym, right? So you see that acronym, what does it mean?
Shortness of breath.
The others, everybody else knew that this was shortness of breath?
I didn't know.
Yes.
Who didn't know?
I didn't know.
Right. So that's the point I am making. So if I am a medical person reading the report and I see SOB and I have a medical background, I will know that that is the shortness of breath. But if you don't have any medical background, it is open to interpretation. And it could be interpreted as son of, and you know the rest, right? So it's open to interpretation. And when you're writing a report, you only put facts, right? We don't put things that would be considered assumptions. So I do support the use of abbreviations, but just make sure that they are accepted within your organization, and be careful when writing a report that you don't use too many abbreviations, right? So, because if it becomes a legal issue, that might be a problem for you if the lawyer get a hold of that report, right? Because it depends on who is reading it. When you have abbreviation, if the person has medical knowledge, then they might be familiar with that particular abbreviation. If they don't, it's open to interpretation. And if it's open to interpretation, it's an assumption. It's not a fact. All right. So that's that on abbreviations. And that would be the end of the medical terminology lecture. Are there any questions? It's a straightforward chapter. You definitely need to spend time with the chapter. If you don't have any medical background, it will be essential to going forward in the course, especially when we start to focus on the human body. Anybody have any questions? Let me start calling name then. Ms. Nesbeth, any questions? Where's Ms. Nesbeth?
No, sir.
Okay. Ms. Johnson, any questions?
Not right now.
Miss Dennis,
No, sir.
Miss Jackson,
No, sir.
Ron.
Quite clear, sir. Quite clear. You are doing us.
All right, good. Good. Now I want to get to the end of this slide. Where is it? All right. So if you have not seen the slide before, answer that question. Raise your hand if you know the answer. Raise your hand. Question 1. Which of the following components of a medical term conveys its essential meaning? Go ahead, Ms. Jackson.
Word root.
You are correct. You are correct. And don't cheat, you know. Don't cheat. All right. Next question. Prefixes can indicate. Raise your hand if you know the answer to this question. I don't want Miss Jackson. Somebody else. We won't get that much time to answer a question, you know.
Body
You gotta
parts.
be on top of it. Young man, you are supposed to raise your hand before you answer. Yes? What was your response, Rowan?
Sorry, sir. Body parts. Sir.
That would be C?
Yes.
All right, that wouldn't be correct. Somebody else want to try? Go ahead, Miss Johnson.
Color.
Color would be correct. So the answer is actually A. All right, thank you. Who have I not called? Miss Nesbeth. Go ahead.
D, brown tie.
Okay, that is correct. That's quite some audio you got there. Next question. Next question. Miss Dennis, that's yours. Go ahead. Miss Dennis, where art thou?
Reading the question.
Okay. Okay.
C.
Go for it. C would be correct. Remember, we won't have a lot of time to read the questions when we're doing the exam. All right, so C is correct. Number 5. Back to that would be Miss Jackson. This is your question. Movement of the arm toward the midline. It said movement. So that's a hint.
Toward. Abduction.
Is that abduction with a B?
Yeah, abduction.
All right. That wouldn't be correct, but then I automatically know the answer now. So,
Oh,
Miss
abduction.
Jackson, just remember, are you familiar with somebody being abducted?
Yes.
So when they kidnap somebody, then take them away, they move them away from somewhere, right? So if it's AB, just think about somebody being abducted. That's a movement of the limb away. So it's being moved away from the body. Add, addition, you're adding something together, so it's coming towards the body, right? So remember that. So the answer would be C. No worries, no worries, no worries. All right, Rowan, your time again. Where art thou, Rowan? Come forth, come forth.
That's a Russell, sir. All right, down here. A body part that lies
Closer to the midline. Keyword.
closer to the midline. That would be proximal. No, medial.
Okay.
Okay.
Medial would be correct. You are correct. I think the next question is Miss Johnson. Come forth in the temple. Come forth. Miss Johnson, this is your question. Go for it.
This is identified that is ventral.
That is correct. That is correct. Another term for anterior would be ventral. Miss Nesbeth, you are up next. Go for it.
Sitting at 45-degree angle, C.
You're reading the question? You're reading the question?
Place a patient in the semi-fowler position for transport, right?
Yeah, man, you're right, you're right. I'm just...
C, sitting at a 45-degree angle. I just read a little fast, sorry.
Yes, that seems like the case, which is not a bad thing. All right. Miss Dennis, I think it's your time again. Yes, should be your time.
A.
Okay. A is correct. A is correct. Right? And the last question would go back to Miss Jackson. So you have the last question.
Using abbreviations, acronyms, or symbols and notation. All of the above.
All right, that is correct, and that's the review questions for medical terminology. All right, any questions? We good? So the rest is up to you. You need to go back, read, study what you need to study. You will definitely see medical terminology on your first written exam, for sure. And there are 2 handouts on medical terminology on the platform. No, 1 handout. Ensure that you spend a lot of time with that handout. How many persons are currently able to access the platform? No one as yet?
No.
I'm still waiting.
I have
No, no, sir.
So I hear Miss Dennis says she's still waiting. Rowan, you just come through, so I would expect that you wouldn't get access at this point as yet. Miss Nesbeth, what were you saying?
I haven't tried as yet.
You were told that you can?
No, because
Okay.
you said that you showed us how to, but so I didn't attempt to.
No, do not try until you get confirmation.
Oh, that means no then, sir. I don't have access
Right.
to it.
So you would have to get confirmation from the IT person through Mrs. Mackay. All right, no problem, no problem. Work in progress, work in progress. Work in progress. All right, let me bring up this. Let's get into the infamous human body. Let's see how far we can get into the human body. We might finish a little early today. I'd finish about 7:30. So it's chapter 6 next, the human body. All right. So it's going to be important for us as EMS providers to be familiar with anatomy, which is structure, and physiology, which is function. So we need to know the structure involved. We need to understand the function of the structure. What do I mean by that? You may have to SWOT the anatomy, but you have to understand the function, which is the physiology. You can't SWOT physiology. You got to understand that. Why is this important? Well, when you have a patient that presents in front of you, the patient will have either a medical issue or a traumatic issue, and a system in the body is affected by that. You must know the system that is affected, and you must know how that particular system functions normally. If you know the system functions normally, then you know what would be presenting if that system is not working properly. And that is the signs and symptoms that you see from the patient. That is pathophysiology. And that is what you treat as an EMS provider. You treat the pathophysiology. So if you don't know what is normal, you can identify abnormal, right? Now, introduction. A working knowledge of anatomy is important. Knowledge of anatomy helps to communicate correct information to other medical professionals and to others who may not understand medical terms. And the focus will be mostly on topographic anatomy, not microscopic, right? You don't need to know that for this particular course. So it's going to be mostly what you can see with your eyes, right? That's what the focus will be. So you have superficial landmarks that serves as guides to structures that lie beneath. Topographic anatomy applies to the body in the anatomic position. And when we talk about the anatomic position, it is the patient standing facing you, arms at the side, palms forward. So let me quickly move to that slide that you can see what I'm talking about. So this would be considered anatomic position, right? And you have 3 planes. You have the transverse plane or axial plane that cuts the body into a superior and inferior portion. We're not going to say top and bottom anymore because we are EMS people, right? Superior and inferior portion. That's a transverse plane, right? Then you have the frontal or coronal plane, which is this one, right? Now, that particular plane cuts the body into an anterior and posterior portion. When I say front or back, right? Anterior and posterior, right? Then you have the, sorry about that line, my hand chipped a little bit. You have the sagittal plane. Now, let's pay attention to this one because it's not really a sagittal plane, right? The plane that we're seeing now is actually a mid-sagittal plane. So we need to understand the difference between sagittal or lateral plane and a mid-sagittal plane. Now this picture is depicting a mid-sagittal, right? A mid-sagittal or midline plane cuts the body into left and right halves. Left and right halves is mid-sagittal. The sagittal plane, which is the one I'm going to draw now, cuts the body into left and right portion. So an example of sagittal plane would be a line drawn from the mid-clavicle or collarbone, the middle of the collarbone, down through the nipple. It's cutting the body into right and left, but it's not equal, right? So a sagittal plane is not equal. It cuts the body into right and left, but it's not equal. The mid-sagittal plane cuts the body into left and right halves. I hope I made that clear. So the diagram that you're looking at, that is what we would consider to be normal anatomic position. So anytime you are going to assess or treat your patient, you always think about the patient in that particular position, right? So if we find them prone, we turn them over and we think about the patient in that position. And it is the patient right and left, not yours. The patient right and left. Now, let me ask a question. This is from Miss Jackson. You see where that arrow is pointing on the forearm with the thumb facing outward? What portion of the forearm would that be? Would it be lateral or medial?
Medial.
All right, so let's back up. Anybody else have anything different? Let me put the arrow on this side. So what portion of the forearm would that be? Is it medial or lateral? Anybody else?
Lateral.
Lateral. All right, so we got two responses. Good. Now, if this line represents the mid-sagittal or midline, anything that is moving towards this midline would be considered, or I should say anything that is closer towards that midline would be medial, right? And let me get my pointer. This portion of the forearm is closer to the midline. So the side with the pinky or small finger would be medial. The side with the thumb would be lateral, right? And we need to get that, you know, have to get that, right? Because remember, we use directional terms to give locations of injuries, right? So when we talk about the lateral aspect of the forearm, we're talking about the thumb side. When we're talking about the medial aspect of the forearm, we're talking about the side with the small finger. I hope I made that clear enough. All right, let's clear up this. So these three planes, you need to be familiar with them. That's a must, right? You need to know what is meant by normal anatomic position. And that's the way we will always think about the patient. Rowan, if this patient had a fracture to the thigh bone in this region, would that be proximal or distal? Is that the proximal end of the thigh bone or the distal end? Rowan. Come forward, Rowan.
That, that would be distal, sir.
All right, so Rowan, do you understand that this is the thigh bone?
No. Yeah, just recognizing what you're talking about. That would be the
Okay,
proximal because it's closer to the trunk, right? Is that the word?
right.
Yeah,
Yes.
yeah, man.
All right, good. Excellent, excellent. Is there anything else I need to point out on this? All right. Go ahead.
Okay. So as it relates to the midline and the lateral. So in no case, it can be a reverse, right?
I don't understand what you mean by reverse.
So the midline, so the lateral will always be on the right, and the midline will always be on the left as it relates to the pinky and the thumb.
I don't like the term right and left, you know. Right? So lateral would be the thumb side because a person can have a fracture and it rotates. Yes? And it rotates to the point that the thumb side is actually closer to the body, but that's not the medial aspect of the forearm because it's not in normal anatomic position. You understand that?
Okay, yes, sir, pretty much, yes.
So you have to think about it in normal anatomic position because that's the position that you need to get it back in to stabilize it. Go ahead, Miss Nesbitt.
Sir, probably what we could remember to make it a little easier for the limbs, the medial aspect always, the inner seam of our garment is always in the medial section, and the outer ones would be in the lateral portion. Just something to make it easier to understand.
If it works, it works. Go with it, right? Go with it. So whatever works, whatever let it stick, work with it, right? Now these concepts are things that you will have to start using, thinking about if you're new to the human body, right? But you can grasp it through the duration of the course. So let me backtrack just a bit. All right, I think I was on this slide. All right, good. We spoke about the anatomic position, patient standing facing you. The head will be in what we would consider to be a neutral position. The arms at the side, palms facing forward, the thumbs pointing outward. Right? We looked at the imaginary planes, imaginary straight lines that divide the body. Three main areas. Frontal, coronal plane divides the body into front and back, but we don't use that anymore. We say anterior and posterior, right? You have transverse or axial plane, which divides the body into top and bottom, but we say superior and inferior. You have the sagittal plane, which divides the body into left and right, and you have the mid-sagittal plane, which divides the body into left and right halves, right? Make sure you know the difference. All right, so the first system that we will look at, and as I said, we're going to stop at 7:30, the skeletal system, right? The skeleton gives us a recognizable human form and it protects vital organs, and it consists of bad TLC. That's my way of remembering it, right? So that's my way of remembering the structures. Bad TLC, bad bones, T, tendons, L, ligaments, C, cartilage, right? The ligaments are present to connect bone to bone, and they help they help to reinforce the joint, right? So they help to keep your joints stable. Tendons connect muscle to bone, right? And when the muscles contract, we get movement, controlled movement. And then you have the cartilage, which is the protective covering over the bone, the ends of the bone, and they are there to prevent friction, the bones from rubbing together, right? And the bones have numerous functions, numerous functions. Ms. Johnson, what is one of the functions of the bones?
Produces red blood cells.
That is correct. So it produces blood cells. Ms. Jackson, give me another function of the bones. Comfort, Miss Jackson. Comfort. Keeping you guys on your toes. Where's Miss Jackson? Okay. Rowan.
Comfort. To protect the internal organs.
Right? It protects internal organs.
Yes.
It manufactures blood cells. It stores minerals. Right? So there are multiple functions of the bones. Now, the skeletal system is divided into the axial skeleton and the perpendicular. Well, let's focus on the axial skeleton first, right? So it is divided into two divisions. You have the axial, and I call it the centerpiece, right? So that's the centerpiece. The skull, spinal column, and the thorax. That's the axial skeleton. I have the appendicular skeleton, which is the attachment for the upper extremities and lower extremities. All right, so let's look at the skull. So the skull consists of the cranium, which is made up of 4 bones, right? And you have the face, which is made up of 14. And every structure on this slide, you need to be familiar with. Every structure on this slide, you need to be familiar with. So you need to be familiar with the parietal bone of the skull, the temporal, occipital, and frontal. Need to know that. Need to know the zygomatic bone, cheek bones, the mandible, maxillae, upper jaw, mandible, lower jaw. You need to be familiar with the foramen magnum, which is the opening where the spinal cord exits the skull and runs down the spinal column. So all of the areas labeled on this slide, you need to know. And we have the spinal column, right, which consists of 33 vertebrae divided into 5 sections. So you have cervical, thoracic, lumbar, sacrum, coccyx, or coccygeal. You have 7 cervical vertebrae, 12 thoracic, 5 lumbar vertebrae, 5 sacral, 4 coccygeal, right? And the spine runs down the spinal column, and there are spaces within the spinal column where you have nerves branching out, right? Nerves that control the upper, lower portion of the body. Then we have the thorax, which is formed by 12 thoracic vertebrae, right? And 12 pairs of ribs. And the main function of the thoracic or region or rib cage is protection of the heart, lungs, esophagus, and great vessels, right? Now, yeah, you have the sternal notch, which is up here. That's the sternal notch. From here to here is the sternum. All of this is the sternum. You have the sternal notch up here. Top portion of the sternum is the manubrium. The middle region is the body. And the tip down here is the xiphoid or xiphoid process, which can be broken off when you're doing CPR, even when your hand's in proper position. Now, from the ribs from ribs 1 to 7. Yes, 1 to 7 are referred to as the the true ribs, right? So that's the true ribs because they are directly attached to the sternum, right? Now, why is that important? It means that if there is a fracture between 1 and 7, it might take significant force to fracture that rib or ribs, right? Ribs 8, 9, and 10 are referred to as the false ribs. So 8, 9, and 10 referred to as false ribs because they attach to vertebrae. They attach to cartilage. They don't attach directly to the sternum. Why is that important? You need to think about what would be in that area. So if there's a fracture within 8, 9, and 10, the patient can have abdominal complications from that. Then you have the floating ribs, right? Which is 11 and 12. The floating ribs have no anterior attachment. So the floating ribs have no anterior attachments, right? And let me just pause right here. So let's recap quickly because I'm gonna stop now. Where we have started to look at the skeletal system. It consists of bones, ligaments, tendons, cartilage, right? The bones have multiple functions. Structure, protection, manufacture blood cells, store minerals, right? Ligaments reinforce the joint, connect bone to bone. Tendons connect muscle to bone. Cartilage is the protective covering to prevent friction. The skeletal system is divided into the axial skeleton and the appendicular skeleton, right? The axial skeleton is the center portion, right? And it consists of the skull, which protects the brain, the eyes, right? The spinal column, which protects the spinal cord, and the thorax, which protects the heart, great vessels, right? The skull consists of the cranium, which have 4 bones that you need to be familiar with: frontal, parietal, temporal, and occipital. And you have the bones of the face, which consists of 14. The foramen magnum is the opening where the spinal cord exits the skull. The spinal column consists of 33 vertebrae divided into 5 sections, right? 7 cervical, 12 thoracic, 5 lumbar, 5 sacrum or sacral, 4 coccygeal, right? Then we have the thorax, which protects the heart, lungs, esophagus, which goes to the stomach, and the great vessels. And it consists of 12 pairs of ribs, right? Some of these ribs are attached directly to the sternum, which consists of the sternal notch, which is a point for inserting what is called an intraosseous needle for severe trauma patients. So we can put an IV, well, it's not really an IV access, it's a intraosseous access, that's the correct term, to run fluids directly into that area. You have the manubrium, which is the top portion of the sternum. You have the body, which is the mid portion. You have the xiphoid or xiphoid process, which is the tip. The pairs 1 to 7 true ribs directly attached to the sternum. 8, 9, 10 false ribs. They are attached to cartilage, not directly to the sternum. 11 and 12 are referred to as the floating ribs. They only have posterior attachment. And that is where we will stop for the human body. We will continue on Thursday. Any questions? Are we learning anything? We're learning? We having fun yet? Yes? Anybody still there? Arna Gasly?
Yes, sir. Lazarus is coming forth, sir.
Sir, you see the picture that you showed us of the skull, sir, with the teeth, with the maxilla.
Yes.
What view is that? Because I don't understand that figure.
I don't understand what you're asking. Let me backtrack.
Like you're looking. All right, go back. Yeah, right. That's one.
Which one? This?
Yeah, that figure, sir. Yes, the one. Right. Where? What kind of view is that? Is it that you're looking down on the skull, or what?
That is this skull. You're looking at think of it as you're looking at the inferior portion. So that's where that opening would be. Right? So the opening for the foramen magnum is the inferior portion. I don't know if that answered the question. That's the best I can tell you. Any other question? So that was Nesbeth, Rowan. Where's Miss Jackson? Where's Miss Johnson? Where's Miss Dennis? You people still here?
I am. Don't have any other questions.
Okay. All right. So you guys need to start your reading. Need to start studying as well. You need to start reading the first 3 chapters if you have not started yet. And I'm hoping that you have already started that. So chapter 1, 2, and 3. You will need to be very familiar with those chapters to complete your first assignment, right? Medical terminology and human body will be your first written exam. I don't think it will be the entire human body chapter at this point. Might be the most important systems at the beginning of that chapter, and the rest will come in other exams down the line. So the work has begun. Ensure that you're managing your time appropriately, right? Ask questions. I might not be able to give you an answer right away. It may require me to go back and read and double check something, but I will provide you with an answer, right? If I don't know, I just don't know, right? But if I tell you that I don't know this particular time, the next time you get me online, I'll have an answer for you. So don't be afraid to ask questions. You have to start utilizing the terms if you're not familiar with them. That's a medical terminology. You have to take the systems in stages. Now, because in EMS, in pre-hospital care, when we assess a patient that is critical, we are looking at the nervous system, we're looking at the respiratory system, and we're looking at the cardiovascular system. And when we're dealing with patients with fractures or dislocations or possible spinal injury, you're looking at the musculoskeletal system. It therefore means that you need to know these systems very well, right? Because when every patient that you assess, you are going to be looking at your nervous system, respiratory, and cardiovascular system. Take it in stages, right? So if it's new to you, take it in stages. Don't overwhelm yourself. All right. I will see you guys on Thursday at 4 p.m. We'll finish at 6:30 on Thursday. Any questions?
Not at this time.
Okay. Now, for the purpose of this course, some equipment that you may need to consider getting, a pen light, a stethoscope, BP cuff, pocket mask, triangular bandages. Right? So if you can get these items, I would suggest that you do, right? For the duration of the course. All right, people, it has been fun for me. I hope it was fun for you. I will see you guys on Thursday.
Thank you.
Will you please repeat what we're supposed to get?
What did I say? Pen light, stethoscope, blood pressure cuff, pocket mask, triangular bandages. Not a must, but if you can get them, that would be awesome. All right. All right, people, that's it. You can leave when you're ready.
Thank you.
Thank you, sir. That's
All right.